then we started seeing more and more. In the morning, you have heard Dr. T.V.S. Gopal mentioning, despite the advances, whatever you have in anesthesia techniques, perioperative management, the recent, the vasopressors, better fluid and electrolyte management, there is no significant drop in the perioperative mortality or cardiovascular risk. What is the reason? If you find a person with a male diabetic who was playing shuttle, who was absolutely all right, ECG echo normal, so what would you do if his calcium score is 100? Will you clear the patient for surgery, or would you go for any other investigations? Similarly, when you find many of my colleagues, surgeons, they send the patient. A patient on a urinary catheter for 8-12 weeks, he wants to get his prostate removed, but then because of the risk factors, because of the age, we conduct an invasive cath or CT, and then we find a proximal LAD 80% or 90% lesion. Patient is absolutely asymptomatic. What do? Surgeon wants, no, I will wait for 3-4 weeks, or he can be on catheter for the 12 weeks. You first fix the lesion, because surgeons are worried, they delay, they are uncertain, they don't want anything to happen. And many, like me, these things happen. The colon cancer in the morning, there was discussion. Likewise, head and neck surgery, abdominal, acute, subacute cholecystitis. Now we are facing more and more of these dilemmas, and most of our practice is cardiology. Patients either had heart failure to have recovered, or post PCI, recent, or 4-5 years, 10 years ago, or post CABG. Some patients have multiple risk factors, absolutely asymptomatic. And day in and day out, I and Dr. Somanath take morning counseling for such critical patients, almost 30 patients, we do the counseling, and we keep seeing, and sometimes we are perplexed what to do. Can we predict properly? You'll see at the end of the session whether we can do that. We know, we heard the magnitude is very, very high, both in globe and India also. And as the coronary screening, what we have been doing for decades together, the routine cardiac screening, hasn't or is found to have so many fallacies in picking up the right patient who really has the disease, who will have problems, who will have in future MI or events or sudden cardiac death, or whether what you are doing, therapeutic decisions like stenting or surgery, will that improve? We will see what happened in the past 40 years, what we have thought, and in the past 3-4 years, how there is a sea change in the landscape and understanding the pathophysiology. And I must tell you, I was thinking artificial intelligence or the machine learning and the quantum computing, hybrid quantum machine learning, all these techniques are useful in all walks of life, and I have seen personally that it helps cardiology patients very much in diagnosis and the therapeutic dilemma, and then picking up the patient much early. But once I started going through this perioperative mortality or perioperative cardiovascular disease, I'm very certain that artificial intelligence is the key. If you want to reduce the mortality from 3.1 to less than 1%, it is possible, but there should be a lot of brainstorming and a lot more data to come, pure data, because AI is supposed to have some biases and all, and then it should go into the public. And the surgeons and anesthetists, unfortunately, past 40 years, cardiology has taken a different direction, and slowly people are realizing. I will not discuss much about pathophysiology of circulatory shock, heart failure, AF, and it's all routine stuff. All senior anesthetists and surgeons and cardiology physicians know. I'll touch upon some bridging. And our institution, how we adopted artificial intelligence, since 1998. I'll just present, and then the future. Future is good provided we have brainstorming sessions and proper thinking and alignment on certain things. When I say that we have not done good job in stable angina pectoris or screening the coronary artery disease patients, because the trials or the standard textbook, Eugene Braunwald, or the discussions in the cardiology conferences, we always focused on symptoms, and we focused on stress test, ischemia, treadmill test or nuclear stress test. And then we were focusing on stenosis severity. This is a recent conference done in San Francisco, October. A very senior cardiologist have mentioned that we have never actually measured the heart disease, but we kept on following certain blind principles, because of which there has been substantial delay in accepting the right kind of investigations. We'll see what is the evidence to say that. Why did he say that? In a TCTMD conference, which is a global conference, you cannot talk, differently. And then the same. I was just asking 80%, 90% lesion, if my urologist wants me to fix up, I'm not sure, I don't know. Because this is a doctor whom we are following since 2017, and repeat CTCA shows almost 80 to 90% lesion. He is asymptomatic, he plays shuttle, and his treadmill is positive. His CT-FFR is positive, 0.78, but he doesn't want, and we also were not sure whether to fix this lesion. So still there are black boxes, still there is an enigma in understanding the pathophysiology and black boxes in terms of microvascular disease, collaterals, proteomics, genomics, lots of things. We know that 50% of the coronary artery disease is because of genes now, which we were thinking 10-15%. No, there are lots of other things, genetic, genomics, epigenomics and all. Now these are the global prevalence of cardiovascular disease. It's going up, and in India, and you have seen that 90%, I will focus upon this perioperative MIs after surgery, and mostly silent and deadly. And these are preventable. How do you prevent? Is it the same routine screening which we have been doing, like only investigate symptomatic patients, or do a stress test before, or do a cath angiogram? This is the system which we have been following for years together. We will see where it led us. And we have seen this. Many deaths after surgery are caused by circulatory failure, and it is the third most common cause of mortality after cardiovascular disease and malignancy. And three dominant biologic killers: myocardial injury, major bleeding anemia, and sepsis. And acute heart failure, one of the dreaded complications. We keep seeing after orthopedic surgery, after cholecystectomy in our own setup, patients who were, however care our anesthetists take, some patients get into failure. So these are all the risk factors. An interesting factor about age, what all these things can we predict better? Do you need for every case echocardiogram or dobutamine stress echo or nuclear stress echo or coronary angiogram to identify a hidden disease? Or is the AI helping us to pick up the right investigation for the right patient? And one of the commonest sustainable arrhythmias is atrial fibrillation. Almost 52 million patients across the globe have this, and it has doubled in the past 25 years. And is there any way to predict? We see, okay, patient 60-year-old, they send the ECG, and perioperative, yes, okay, go ahead. Does he need any prophylaxis for atrial fibrillation? Is there any method? Does the ECG tell you that he is likely to get into atrial fibrillation so that he can give prophylactic amiodarone or beta blocker or colchicine or whatever to prevent this? Because even one episode of transient AFib has got longer implications for 30 days or even at 1 year. And also, the aspirin, the routine aspirin which was being given and then which was withdrawn, is aspirin indicated when you find some inherent or hidden disease? So we know all these impact of atrial fibrillation, and the two-hit hypothesis, whether it is cardiogenic or vasodilatory or single shot where after cardiac arrest the patient goes into these, and then Dr. Mahesh has very clearly explained, be very, very careful in managing the shock. Another very important aspect in perioperative cardiovascular diseases, after the surgery, as in the morning was showing, our surgeon felt very happy that while doing the skin sutures, till that time everything was very stable. He praised the anesthetist, but suddenly patient had a cardiac arrest, ventricular tachycardia. And similarly, there is a high incidence of perioperative increase in the troponins. It is silent, most often asymptomatic, unless it is very severe, massive MI patient won't have symptoms. So it goes silent, and there are longitudinal studies that rise in troponin in the initial 48, 72 hours, it results in longer, higher mortality at 30 days and 1 year. So, and if you don't track patient beyond 30 days, venous thromboembolism is another complication. Most of the time, 50% of the times, they present with pulmonary embolism. They won't come with pedal edema. They won't give you time to do venous Doppler. So you have to be very cautious in terms. We initiated a 3 to 9 post-discharge surveillance program for 42 days, for which we got a award in FICCI and Asian award for that, because we followed the patient for 42 days by either telephone or sometimes visiting. So post-operative care of a major surgery is very, very important. And again, the same thing. This I am bringing it because despite the identification, William Harvey of circulation, Einthoven's ECG in 1904, Linac and Braunwald's Bible cardiology, we hear day in and day out, sudden cardiac death. Is it predictable? Yes. Now we know 80% of the World Heart Federation says 80% of the sudden cardiac deaths are preventable. Either lack of awareness or access, ignorance, denial, lots of factors play, cost, all this expenditure. And there are several articles in the past 7-8 years, not only 7-8 years, almost 15 years, that there are certain procedures which cardiologists are following which are not right. There is clear evidence by following several lakhs of patients. What are those? We'll see. All cardiologists have been following globally, whenever you want to screen a patient, somebody uses treadmill test, nuclear stress test, or dobutamine stress test, and PET CT, whatever, depending on the availability, number one. And then symptoms are very important before suggesting. Stress test is priority before taking the patient to cath lab. And in cath lab, it is the two-dimensional tubular vision and 50% stenosis, arbitrarily fixed 50% stenosis. And then lots of other things, lots of debates in conferences, and there is no uniformity. I think Mahesh will be knowing, most of the people will be knowing, 80% lesion in 3 vessels. What do? This is the most of the topic discussion between cardiologists, surgeons, and a lot of, discussions, literature, quotes and all. This is despite almost 1984, probably this marathon runner, Jim Fix died, who was a marathon runner, whereas the other person. So people identified that risk factors are not really only factors based on which you should investigate the cases, because there is a paradigm change in the understanding of pathophysiology, where instead of fixing a stenotic lesion, now you are talking about vulnerable patient, vulnerable plaque, and then vulnerable condition, and then try to fix it. But that area, before going to that, just I'll talk about this. Artificial intelligence has created a lot of interest, debates, doubts, but I am very sure that it is a definite aid to all the physicians, and especially in the perioperative period, anesthetists can utilize it to bring down the morbidity and mortality. And AI, its health benefits, how it helps in several areas of diagnosis, imaging, computer vision, large language models, lots of things, speed workflows, all these things. I will not talk much about this quantum. Otherwise, European Journal recently, all the areas where AI can help in different departments, and then how it can quickly cut down the documentation time, and future, lot of future with AI, autonomic robotics and all these things. So in cardiology, in every department, congenital, cardiac, cardiomyopathy, CADs, everywhere AI aided CVD diagnosis, and ultimately it is the multimodal fusion model which will give us a more direction, better direction, whom to investigate, how to investigate. Now you were talking, I was talking to my anesthetist yesterday, who was saying a 25-year-old guy who comes for a minor surgery, and do you want to take an ECG? No, he says, no, I don't want. ECG, what does it tell me? A 25-year-old guy is asymptomatic. ECG will tell you, AI ECG is now telling us much more than what we were imagining, and we used to screen the ECG and say, okay, you go for surgery. But now we know it gives us information about the cardiomyopathy progression much before it progresses or it shows up in echocardiogram or clinical symptomatology. Maybe in some cases several years ago, several years before. Lots of algorithmic voltage and complexes and all these things. And then there is something like heart delta age. AI is now able to give AI age minus chronological age is called heart delta age. If heart delta age is more, then patient is likely to succumb to several complications and lifestyle factors. And so AI is now also in structural diseases. So amyloidosis, hypertrophic cardiomyopathy, dilated cardiomyopathy, all these structural heart diseases, aortic stenosis, early diagnosis, severity of the stenosis, mitral regurgitation, then it has transformed, and many times we see ECG shows non-specific STT changes, right? We were thinking that these are benign. In fact, textbooks also mention non-specific STT changes are benign. But now they have seen adjusted odds ratio is 3.15, and non-specific changes imply that there is some myocardial fibrosis or remodeling. It will lead to something else in future. Similarly, the culprit vessel, many times in the ER, we see lesions, we see ECG, we cannot pinpoint the artery closure. Now, simple ECG, what you cannot see, it can identify whether it is occlusive MI. Now, the terminology of STEMI is changed. The European guidelines say occlusive MI, or is it reperfused, which vessel, all these things, it will tell. So, Wellen syndrome, T inversion, so it is a reperfused vessel, it will tell, AI will tell. It is much better than human eye and cardiology, senior most cardiologists. So, and then the prediction models. False, there is something like AI false ECG. They have followed. Echocardiogram is normal, LV function is normal, and then it has shown that over a period of time patient develops, it is intermediate phenotype. So, AI ECG can pick up heart disease with preserved ejection fraction, heart disease with intermediate phenotype, where it will get into problem. And then normal ejection fraction over a period of time, how it will pick up. Then coronary artery disease, incident coronary artery disease, it is able to pick up. You see the ECG and some voltage, some areas, it says no, this is equal to clinical risk scoring. It says this patient has got coronary artery disease. Absolutely normal ECG, normal echocardiogram. So the saliency maps, that is what we call as heat maps in artificial intelligence, explainability. Now it is able to explain. This is the reason why I am telling you that this patient is likely to have CAD. These are called saliency maps. And explainability was a big problem with AI earlier. Now it is able to tell us in many areas why it is saying so. It will tell now. And then lots of pericardial ischemia. In a perioperative area, it's difficult because the leads are different, and then patient is asymptomatic, only cardiologist, no angiogram is done. So it is difficult here. Similarly, post-operative atrial fibrillation, as I mentioned, whether is there a role of trying to identify atrial fibrillation before sending the patient to the OT, or taking a consideration and other factors, or during the post-operative period after discharge. So likewise, similarly, X-ray, echocardiogram. Now you have lots of portable echocardiograms. Even on walking, it's a portable patch echocardiogram. You can have the lesions. So it is 600 times faster, and then you don't need echocardiographers. Even a simple nurse has recorded these echoes just on the direction, and then automatic rotor, it can give you the direction how to place this. So likewise, the current echocardiogram, it gives a lot of information. And before that, as I mentioned, ECG gives a lot of information, which I never imagined, maybe about 2 years ago. Only 2-3 years ago, the articles have been pouring in about AI ECG. It is equivalent to methylated DNA, which gives an estimate of longevity of a person. It is equivalent. So hemodynamic prediction, Mahesh mentioned, and then now the goal-directed fluid therapy, then stroke volume variation, and pressure volume variation, all these things, and it gives direction. It takes. The AI is going to study the patient completely in the OT, real-time dynamic monitoring to prevent intraoperative hypotension, the duration, the sepsis, the bleeding, everything it will take into consideration. And now you have something like digital twins, which I will be talking to you, how it has helped our cardiologists in identifying the disease much early and sudden cardiac death preventable. So this is digital twin. Where is it? Now in CT coronary angiogram or in surgeons, where you identify 3D printing, you identify disease, you operate, and then you know what are the problems. So real-time transfer of the data, wearable data, daily whatever activities, and then the genomics, epigenomics, everything is fed into this in silico digital twin. And now for the functional aspect, anatomic, now the CT FFR, I'll be showing AI CT plaque morphology, hemodynamics, the feature extraction, segmentation, computer vision, everything is AI now. What all we have from heart flow about the CT-FFR and how to identify. I mentioned about 80% lesion in the question. My urologist says, no, I won't operate. You first fix it. I won't fix it. I'll fix it if my digital twin, the information which I got it through these experiments, if it shows a very highly vulnerable plaque, that is high cholesterol, low attenuated, with lots of positive remodeling, and such patients, necrotic core, probably I won't use a stent because he will need surgery. I'll use a drug-eluting balloon in such patient. If it is a calcified, fibrotic, and there is not much of non-calcified segment, I won't fix it. You go ahead with surgery. I am there. In case you develop a problem, we'll fix it at that time. Because we know that there is no evidence to say that in asymptomatic or stable angina pectoris patient, even if you have triple vessel disease, if there is no left main disease, there is no evidence to suggest that treating the lesions, fixing the lesions will improve the symptomatic status or the longevity. So why do I fix up now in the pre-operative period when there is no evidence, and when we are fighting out whether to fix or not, even cardiologists, there is no uniform opinion how to investigate, how to treat, how to take the therapeutic decision. So this is how the digital twin is now going to take place in healthcare, cardiology, and even your oncology. Digital twins, what are the biomarkers and all. Lots of applications are there. And yes, this is the intelligent ICU. And what all we have been doing so far, as I said, we have been doing wrong in the past several years, 40 decades we have been blind, because we have been relying on risk factors to pick up a patient for screening of the coronary artery disease. And we know that much long ago, only 60% of the patients have singular, no risk factors, all acute MIs. And all the patients admitted in our ICUs, if you see, 60% of them don't. If we see the patients admitted in our ICU one day prior, we would say, you don't need anything. You are a low risk guy. You are an intermediate risk guy. So you don't need statin, you don't need anything. But this patient has got double or triple vessel disease by that time, which I have missed with all my experience in my OPD. Because as per the guidelines, this and this, the colored charts are there, which are wrong. In Indian patients, especially, these are wrong. We cannot apply whatever Western standards, Western guidelines are there. And this is what the data available much long ago. And now we know these are the two important studies, escapees in Miami heart study. If you take the people in the Western population itself, Sweden and US, more than 45-year-old, almost 50% of them have some subclinical atherosclerosis. 5% of them have severe degree, more than 50 to 70%. Some of the 1%, 1.5% have left main disease. And you are missing this 50% by not doing investigations. And I am sure these 50% people are the people who develop perioperative myocardial infarction or increase in the troponins, which go undetected. So these unidentified lesions. And we know pretty well that finding troponin is going to worsen the prognosis, long-term outcomes. Then why not you pick up? You have to pick up the hidden disease. Supposing hidden disease you picked up either by invasive cath or non-invasive cath, if the coronaries are normal, almost be certain that the patient will not have rise in troponins. This is shown in thoracic tumor patients. They have done the CT in 84 patients, CTCA, and wherever the lesion they have avoided, almost maybe 17% or so had, and then they avoided, and mortality was only 1. So much less than 3.6%, whatever was mentioned. So it is possible in oncology patients, in all surgery patients, to bring it down below 1%, provided you have clarity in what you are doing. Just looking at the ECG, looking at the X-ray, looking at the echocardiogram is not going to solve. For any number of years, same surprises you will continue to have. And this is, escapees in Miami trials. And we know pretty well, the another most important thing I would tell you, we were taught that more than 50% only stenosis is important. But we know that majority of the heart attacks happen when the lesion is only 30%, 40%, less than 50%. That is a vulnerable plaque where the cap thickness is less than 65 microns, and that ruptures in an environment like perioperative period or lots of other factors, infections, inflammatory status, and all these things. This was known 1988, 1990s. But still we have never given importance that less than 50% also can cause problem. Only after the AI directed, the long-term studies, Scott Hart, ICON, and then PROMISE studies, then only you got this. So this is known, and it is not the 50% stenosis. There is no sacrosanct, and we have removed the recent AHA guidelines removed. And now the idea is to pick up, there is a genetic preponderance, despite having either risk factors or no risk factors, either hypercholesterolemia. 50% of the patients don't have hypercholesterolemia, CAD patients. So pick up whether the patient has got a genetic preponderance or predilection to have a plaque, then hit it. Hit it early. The plaque is spongy in 35, 40, 45, 50 years, not at 60, 70 when the patient had MI. However, whatever amount of statins you give, nothing will happen. Already by that time, there is a calcium, there is fibrosis, there is a plaque growth. You hit it when it is 30%, 40%, 50%. And then if not, statins, at least aggressive lifestyle measures, pressures, blood pressure 120 to 130, exercise, yoga, aggressive body mass index, that will bring down, at least retard the progression of the coronary atheromas. Means, as we mentioned, so this can be prevented if you identify subclinical advanced atherosclerosis. At least you are more cautious. And stress test, millions of stress tests are done all over the globe, including India. I know a patient who goes every year to get a nuclear stress test in Hyderabad, right, with 10 to 12 to 15 millisieverts of radiation. So the guidelines, everybody did not believe this, that CT coronary angiogram and CT FFR are much superior to cath till 8 associations came together in 2021. 1990, coronary calcium score was identified, but the paper was rejected by AHA. And 2010, they have identified that stress test, whether you do treadmill test or dobutamine stress echo or MRI or dobutamine PET, more than 90% do not have actionable information. That is known in 2010 if you see the papers. But nobody believed till these guidelines in 2021 came that stress test cannot be used as a screening test. It's a second line of test. When there is 70-80% lesion, when you want to correlate with the patient's symptoms, we have cut down our stress tests by almost 90%. So this is what made whole gamut landscape of our coronary artery disease screening, and the same thing applies for your perioperative myocardial infarction or perioperative cardiovascular disorders, disability or complications. So it should not be paid part. This was there almost in 2018, but it took a lot of time for the people to accept this is how the coronary calcium looks. And then now 2024 AHA guidelines now allow anatomy first approach. It is not the physiology. AICT FFR, the perfusion CT and plaque quantification, the more the atheroma, the more the complications, whatever you do. Degree of severity of stenosis has got lesser importance compared to the plaque volume. And now people have realized that is a two-dimensional coronary angiogram, invasive cath, with all its limitations, is much inferior to a three-dimensional CT coronary angiogram if properly done under proper conditions with proper heart rate control. And then you identify the vulnerability plaque, and then this is how it is. And then perivascular fat attenuation. Then another inflammatory marker. If 3 vessels are there, if perivascular fat attenuation is there, that particular vessel is responsible. The lesion, 80%, that particular vessel is, you can address. Similarly, there was a lot of hue and cry about the radiation of CT coronary angiogram. All wrong. Compared to the invasive cath, CT has got 50% of the radiation, millisieverts. Many of our patients we do with 2 to 2.5 to 3 millisieverts. A cath, if an abnormal coronary artery is there, right coronary artery, we have been struggling for hours together, getting 15 millisieverts of radiation when we did not know RCA coming from left side. We struggled and struggled to get the RCA. And then why should a cardiologist why should the staff get radiation when you can get a better information? And then the mammogram calcification of the arteries is a surrogate marker of coronary artery calcification. So invasive coronary angiogram, this was an opinion, stop. It was done almost 2015 or so, but it took several years for it to be accepted. This is AICVD, and then the diagnostics, I'll just pass on. And the enigma of sudden cardiac death, 50% of the cases occur in asymptomatic patients. Avoid catheter first mindset. Nowadays what we do, now for any lesions we identify, we sit in the CT console room, we give counseling, we discuss the heart team meeting happens there, we know which vessel should be addressed, we call the attendants, we give them time. Earlier what were we doing? Going to the cath lab, doing this, no, you have two blocks, I'll fix up 2 stents. Patient is confused, attendants are confused, they are not prepared, and that caused mistrust. For coronary artery disease, but cardiologists, mistrust is because ad hoc procedures with unprepared mind. Now, CT guided PCI is going to remove all these probably in future misconcepts in the society. And then, okay, bridging, I'll just pass on. This can be shared to you what all I could gather, different scenarios, not uniform measures are not uniform, drugs are given, not uniform periods are given. Again, it depends on the patient, the substrate, the type, the bleeding risk, the thrombotic risk, the genetic risk. We don't know in an individual patient. So the clinicians struggle most in these areas, and then definitely they have to have more information. A team has to form: cardiologist, cardiac surgeon, anesthetist, surgeon, intensivist, to discuss, especially post-operative cases, major cases, what is happening if something happens. So periodic meetings, then whether to proceed or postpone, it has to be decided, not just out of fear for the surgeon. We have to be confident and we have to be prepared if problem occurs in 1 or 2% of patients. Let us be prepared. Don't delay, postpone surgery. Postponing the surgery is hell of a problem. When we postpone a CABG patient, when 20 attendants come from different places and we say for some reason mild fever or sugar is 300, we are postponing, then they get upset. So postponing a major surgery, especially onco surgery or cardiac surgery, is extremely difficult to convince the attendants. So you have better information, better counseling, better team effort, and then this is how you do. And then certain new drugs, what to stop, what to give, and dangerous combination of drugs. All these things we should be very thorough and then be prepared when you are giving. And Cangular, as mentioned, is a recent drug. Probably it will help in better bridging in high-risk patients. So what did we do in our institution? Computerized ECG, we donated in almost 16 places, almost in 2000, and for 20 rupees ECG, and we were getting through the fax machine. That time mobiles and all WhatsApps were not there. So we started giving it to the peripheries, mandals, and then we were receiving it through the fax, and then there is another device, R10 device, where we gave in the peripheries, and we could get to our place. And then these are all the machines, whatever is technology is upgraded, we started getting it, like right from IVUS, OCTs, everything. And then even coronary angiogram, now virtual FFR. Instead of wire-based FFR, virtual FFR. We have virtual FFR with us. We haven't used it much because we have CT FFR. And then these are all the newer, whatever newer thing was there, we tried to acquire it. Now with the CT FFR, what we do, we discuss, and then it is much better idea, and then preparation for us. This is what I was telling, digital twin. The stenting, post-stent physiology, I can know by digital stent. I know where to stop the stent. If there is a lesion below that, and then it gives, no, that doesn't work. Select a bigger length stent, which you cannot do in cath lab. In cath lab, there is spasm, tubular vision, and in ad hoc procedures have the stent dimensions which are inferior to a well-prepared CT angio prepared this thing. So now the dawn is here, and then CT guided PCI is going to be a norm rather than an exception. And then IV contrast has got much lower kidney toxicity compared to arterial contrast because it goes a first pass effect of the kidneys. So these are all the adoption where we have done. We have an intelligent hospital network, and Dr. Karthikeyan will speak about this. What all we have done, tele-ICU, we do tele-ER triaging, tele-ambulance triaging, tele-ICU triaging, and then tele-OT. We added from the OT, monitor is directly seen there. So how the transient problems, because you can't fix, the operative OT staff cannot fix the gaze. So whenever there is a thing, and then you can predict the hypotension. There is a prediction algorithm for peroperative, intraoperative hypotension, sepsis, prolonged, bleeding, everything it can predict. And then if you have a digital twin, it will have a simulation, and then it will give us future. It won't take much, 3 to 4 years, 5 years from now, we are going to have everything. This is what we have, and we have something like when there is an abnormality, even in Mongol patient, if there is some problem, she picks up a phone and says, ward number 6, you have a problem there. This is tele-ICU, what we have. All these are our own innovated, technology here. Otherwise, it would cost several, few crores. So this is how we give the signal and all these things. So we find that definitely AI is helping us quite a bit, and all these things are there. And then we are into almost clinical studies, 28, more than 28 FDA approved studies. Every molecule, ticagrelor, PCSK9 inhibitor, lomocrite heparin, we are participants in this contribution. All these are FDA approved studies only, and then we were recognized for the better quality. But with whatever is said and done, we always keep, whenever some newer device or newer drug is introduced, we are always careful not to adopt it immediately because of these, lots of debates for whatever reasons. During the COVID period, we have seen how biased were some of the organizations, and then the person who was there as an editor in New England Journal of Medicine says, I can never believe the studies. Some are genuine, definitely. You have to identify. You apply your mind, what is really good, and then let it be there in the market for some time before adopting. That is what the policy, which some of the drugs we have never used, and then they were withdrawn from the market. So this is where we are, and even now there is a lot of debate. In routine cardiac patients, if you ask three vessel blockade what to do, I cannot tell you anything. Because per-operative, there are several things which we do not know what is going to happen. What is this hypothalamus pituitary adrenal axis? What are the proteomics? What is happening? What are the drug effects? Drug effects? What is the anxiety and then the nutrition problems? What are these contributing to? So, very, very difficult to bring down, but there is a scope. We know that something is happening, something we are missing in routine cardiology practice. Now, sudden cardiac deaths, 80% are preventable. Why we are not able to do? Because it took pretty long time for the cardiology community to accept what is the reality. Now everybody is accepting, and it will take a while. So future is going to be something like, all multimodal fusion models which we use, and a real-time model with a digital twin, and then with the helping the anesthetist, cardiologist, physicians, that will definitely bring down the routine patients, and we stop static guess. From there we go to dynamic, continuous, updated probability. How is it? Then the ML risk models, then the intra-op, post-op monitoring. And in India, over a period of time, I'm sure we are going to have universal health program from April 1st. And everybody is going to have a unique ID number soon after birth. The government is very keen on improving the overall health of the population in such a vast country. We are very happy about it. And then you are seeing the airports, how your life has become very easy. Likewise in India, with the present steps which are being taken in healthcare, the central authorities, I'm very glad that we are going to show some improvement in bringing down the rank. India is almost 136 rank in healthcare. It is likely to come down to less than 50 in the next few years. But with all these things, still in the morning time, some cases we are perplexed, we have debates, we have the cardiology meeting, and then one cardiologist says something, but more or less objectivity is now there with AI. Objectivity is there. Rather than a tubular vision or just visual estimation is no more accepted. Somebody sees something, 50%, 70%, not many lesions. The angles are there in cath angiogram. Earlier we were all seeing this variance. And then people are dogmatic sometimes. But anyhow, so thank you once again. I'm sorry if I have taken longer than the time which I was allocated, but this is what I wanted to say. Definitely there is a scope for improvement in operative reduction in the cardiac disability and mortality.
Thank you, sir. Since we are already overshot the time, we are now proceeding with the inaugural and felicitation ceremonies, and request all the delegates to stay back, and also request the invited speakers to join us and receive our heartfelt gratitude during the felicitation ceremony.
Good morning to one and all. Present here on the behalf of Aster Ramesh Hospitals, we extend warm and heartfelt welcome to our esteemed guests, dignitaries, faculty members, staff, students, and fellow consultants. To commence the program, I invite the honorable dignitaries onto the stage. I warmly welcome Mr. Ram Mohan Rao sir, Chairman Aster Ramesh Hospitals, to come onto the stage. I invite Dr. Ramesh Babu P, Managing Director and Chief Interventional Cardiologist, Aster Ramesh Hospitals, to come onto the stage. I warmly welcome Dr. Chaitanya Kumar IS, an eminent academician and leader in transfusion medicine and hemotherapy, as additional professor and head of Mangalgiri AIMS. His contributions span clinical excellence, academics, research, and health system strengthening. He has played a pivotal role in developing advanced blood center services, national programs, and accreditation initiatives. With significant research output, patents, editorial roles, and national recognitions, he exemplifies innovation and leadership.